Sorry, I had to break right in the middle of chest tubes. But just to summarize, nurse's responsibility when someone has a chest tube is we monitor vital signs and respiratory status. We assess that the dressing remains airtight. We're going to tape the tubing connections and inspect for air leaks. So everywhere that there's a connection right here, we use just good old-fashioned tape to just double guard against those coming disconnected. The drainage system itself will be kept on the floor, and unfortunately it's really lightweight, and I always fear that they're going to tip over, but I've never had that happen to one. So we keep this on the floor below the patient. And lastly, we observe the chambers for the correct bubbling. So again, in the suction chamber, we should see gentle bubbling. That means it's connected to suctioning. In the water seal chamber, make sure that the level is to the mark on the apparatus, and we watch for tidling, just that gentle up and down movement with respirations. And then in the measurement, now if this is just treating a pneumothorax and it's removing air, you may not have any or very much drainage here. This is mainly for when you're draining fluid off of the lungs, but make sure that it's not filled. And again, we don't ever empty this. We would just have to change out the whole device. This is something that, just adding here, it's not really in your book, but this is something that paramedics carry now. It's a one-way flutter valve, and it kind of acts like a chest tube without having the apparatus, so they can put this in, and it has a one-way valve that allows air to escape but not re-enter the pleural space. So you can't really use this to remove fluid, but for a pneumothorax in an emergency situation, that can be used, so that's pretty cool. Let's look at some sample questions related to chest tubes. There were quite a few in your NCLEX review software. This first one says, the nurse notes fluctuations excuse me, of the fluid level in the water seal chamber of a chest tube. Based on this observation, what action would be appropriate? Well, hopefully you remembered that you're supposed to see tidling in the water seal chamber, so continue to monitor this and expected finding. Here's another sample. Which findings would the nurse expect to note while monitoring a chest tube drainage system in a post-thoracotomy patient? So this is a select all that apply, so let's look at each one of them. Excessive bubbling in the water seal chamber. Well, here's the key word here, excessive. We shouldn't see excessive bubbling. That means if we see excessive bubbling in water seal, that can indicate a leak. 50 milliliters of drainage in the drainage collection chamber. Well, that sounds reasonable. If they just had a thoracotomy, we would expect there to be quite a bit of blood or serosanguinous drainage. 50 milliliters isn't a huge amount. One of those little plastic medicine cups holds 30 milliliters, so this would be the equivalent of a little less than 2 medicine cups, so it's not an unheard of amount. The next one, fluctuation of water in the tube of the water seal chamber during inhalation and exhalation. Again, we call that tidling, and we like to see that. That means everything's working. Next, the drainage system is maintained below the client's chest. Yes, we want to see that. And finally, an occlusive dressing is in place over the chest tube insertion site. And if you recall my picture that I showed you, yes, occlusive just means that you cannot see through it. Well, I was going to go backwards, but that's not working. Okay, here's another sample question. The nurse checks a closed chest tube drainage system on a client who had a lobectomy of the left lung 24 hours ago. So again, we have a fairly fresh post-op patient. There has been no chest tube drainage for the past hour. What should the nurse do first? Well, 24 hours after a lobectomy, we probably would anticipate there to be some drainage. So I'm thinking this is not normal. So our choices: contact the registered nurse, check the client's blood pressure and heart rate, check for kinks in the drainage system, and connect a new drainage system to the client's chest tube. Well, we want to avoid this last one if at all possible, because that's a huge deal. But if you were getting drainage and all of a sudden it stops, to me the first thing I would do is see if there's a kink in the tubing. That's cutting it off, and in fact that is the answer here. And what we hope doesn't happen, but does sometimes, a chest tube gets caught in the leg of a chair and accidentally dislodges from the insertion site. Which action should the nurse implement? Change the dressing site on the chest, reinsert the chest tube using sterile technique, cover the insertion site with sterile Vaseline gauze, or transfer the client back to bed and encourage the client to breathe deeply. Well, hopefully you remembered me talking about Vaseline gauze. And what should happen, it may not happen, but what should happen is there should be a unopened package of Vaseline gauze anytime you have someone with a chest tube. It should be on their bedside table or someplace handy in their room just in case this happens. And Vaseline gauze, just FYI, comes in a foil type wrapping. But anyway, that's the best thing to do. If you don't have that available, well, we just hope you have that available. We're not supposed to reinsert the chest tube. It will have to be reinserted, but a physician would do that. Changing the dressing on the site on the chest isn't going to really address the problem that their chest tube is out, and certainly transferring the client back to bed and encourage the client to breathe deeply isn't going to help either. So in those questions addressing care of the chest tube, several types of surgeries were mentioned. One of them was the thoracotomy, another was a lobectomy. So before we go on, let's go ahead and define what these different surgeries are. Thoracotomy is just simply the surgical opening of the chest. We may or may not do something when we have it open. Pneumonectomy, removal of an entire lung, whereas a lobectomy, removal of one lobe. Do you remember which lung has 2 and which lung has 3? Hopefully you remember the one on the side of the heart just is smaller and has just 2. Segmental resection is removal of the section of the lung, and wedge resection is a removal of a small triangular section. Usually these are done for cancer, and of course the less lung we remove, the more lung is left for someone to breathe with. And so if a physician can get by doing a wedge resection instead of an entire pneumonectomy, they're going to, because that's better for the patient in the long run. Post-op for the thoracic surgery, a lot of the things are post-op are for any surgery. It doesn't matter if someone has their gallbladder out or what, we still want to do this turn, cough, deep breathe, but especially for anytime we're dealing with the chest, it's really going to hurt the patient when they do the turn, cough, deep breathe. So we need to teach them how to splint their incision so it produces some counter pressure and relieves the pain of coughing. As for positioning, we're going to have the height of bed elevated 20 to 40 degrees, and in the immediate post-op, they might be put on their unaffected side, but later on, in order to eat and drink and stuff, they'll need to be on their back. What we never want to do is put someone on their affected side, especially if they've had a pneumonectomy or even a wedge resection, because remember, there's going to be kind of a blank space there where a lung used to be. And if we put them on the affected side, it can cause everything to shift over there, like the heart, for instance, to shift over into that blank space. That's where we talked about that tracheal deviation, and that is no good. We don't want things shifting over, because the heart and the aorta do not like to be moved from where they are used to being put. So we don't want to cause what's called a mediastinal shift. The post-thoracic surgery patient is at risk for pneumonia and atelectasis. Again, that's the collapse of those tiny alveoli for numerous reasons. First, the effects of the anesthesia, which impairs what we call ciliary motion. Drugs that are used often dry secretions, so we really want to encourage fluids to thin out those secretions so that they can be coughed up. And then, of course, just the general immobility. So that's why it's so important to turn, cough, deep breathe, and use that incentive spirometer if we have that available. Okay, finally we get to move on to problems or specific problems with the respiratory system. We're going to revisit some of those different procedures as we discuss the problems that they treat. So a lot of it will be repeat, but we'll discuss the various disorders, and I'm kind of going to work from top to bottom. So we're going to start with sinusitis. You can see some of your sinuses are up in your head, others are behind the nose. And if you want to follow along in your book, we're on 539. Sinusitis is usually bacterial, but it can also be viral or fungal. And the most suggestive sign and symptom, I'm going to say, is purulent nasal drainage. Purulent means pus, and so we're talking about nasal drainage that's yellow or green, not clear. And in a little bit, we're going to talk about acute rhinitis, which is the common cold or even allergic rhinitis. And sinusitis differs from those two in the fact that you're going to have colored nasal drainage. And even my mom, who was not a healthcare expert, knew that. And so when I would get sick as a child, which I did a lot, she'd want to see what was in my Kleenex when I blew my nose. And so if what was in the tissue was clear, we just dealt with it at home. And if what was in the tissue was yellow or green, to the doctor I went. And so turns out she was actually pretty smart. That's a good way to go, because if it's green or yellow, it might be a bacterial infection, in which case antibiotics can help. So sinusitis is going to have that purulent nasal drainage, as well as just general cold flu-like symptoms: headache, fever, elevated white blood cell count maybe. Fever probably won't be real high, so we'd call it a low-grade fever. Treatment, and you're going to see pages like this and for treatment for a lot of things. So antibiotics, again, because we're talking about a probable bacterial infection, although if it's viral, we're not going to use antibiotics. Antibiotics don't help viral infections. Decongestants. Sudafed is a very powerful decongestant, and a lot of times Sudafed or pseudoephedrine, which is the generic name, can be added to products like Claritin. So if you have something like Claritin D or Allegra D, that means the D stands for decongestant, so it has an added decongestant such as pseudoephedrine in it. And nasal corticosteroids, again, there's nothing better at relieving inflammation than a corticosteroid. And the ones that are provided spray, I don't have a picture of any on here, have fewer side effects than the oral. Second generation antihistamines are okay to use, and I have two here. I have Allegra, Claritin, I have three, Zyrtec. First generation antihistamines like Benadryl are contraindicated for sinusitis because they're too drying and they can actually make the symptoms worse. So I have here no first gen antihistamines like Benadryl, too drying, but these second generation newer products with fewer anticholinergic side effects are okay to use sometimes. Other things, non-pharmacological, warm shower, this neti pot, I think it's called, so a sinus rinse, lots and lots and lots of water to thin those secretions, maybe adding humidity to the air, and of course, lots of tissues, but this will especially be affected after you take a hot shower and then blow your nose. That can really help a lot with relieving the sinusitis. Acute rhinitis shares a lot of the signs and symptoms, but here's the biggie right here: clear rather than purulent nasal drainage. So this is usually viral coryza, which is also known as a common cold, or allergic, which is sometimes called hay fever, but just results from being allergic to like pollen or something like that. And again, we're going to see clear nasal drainage, but a lot of the other signs and symptoms are the same as sinusitis. So the main thing you're looking for, just like my mama said, look for that yellow or green drainage that tells you if you're talking about sinusitis or just good old-fashioned common cold. I probably don't need to tell you the signs and symptoms of allergic rhinitis or acute rhinitis, because almost everyone, or I would guess everyone at some point in time, has had a cold, and so you know what the symptoms are: runny nose, nasal congestion, and again, the clear nasal drainage, sore throat. Most frequently, these occur in the winter months when people tend to stay indoors and they can more easily contaminate one another. And people are most contagious during the first 3 days, although these can often last up to 2 weeks. Medical treatment consists of plenty of rest, lots of fluids, and some of the same things that we saw on the acute or the sinusitis, second generation antihistamines, decongestants, and then allergy desensitization if it's the allergic rhinitis. So here's a sample question about acute viral coryza, or the common cold. Is it contagious and spread by droplet infection? Yes, it is. Complication of viral coryza are more common in people with increased resistance. No, that should be decreased. Complications include otitis media, that's ear infection, sinusitis, bronchitis, and pneumonia.